will have 4 speakers with different roles and involvement in the TB programs. And the objectives of our session this afternoon will be to share the current status on where we are on TB epidemic, what is the challenge, what has been done, and we will also learn from the host country, who is Zimbabwe, on the achievements, the challenges, and to implement the TB and TB strategy. We'll understand as well the perspective of civil society on TB financing and the role of the African TB caucus, and also to discover the high-yield intervention that have worked in specific contexts by the Orium Institute. And then we'll have a Q&A how to exchange to identify this high priority intervention with interactive participation. So not to delay the presentation, the first speaker will share with us the overview of this TB epidemic, the key challenges, the progress that we made in the African region. So the first speaker will be Dr. Abena Jean-Louis. He's a public health professional officer with 30 years of experience in global health. And he was worked as a doctor in a rural area in the district functional for primary healthcare planning and the head of the tuberculosis control program in Cameroon. And he held a doctorate of medicine, a master's degree in global health, a certificate in tropical medicine, and currently he is the regional Green Light Committee for TB based in WHO Africa for the African region. So this is your turn to take the floor. Over to you.
Thank you very much. I'll stand up, please. Can you upload the first presentation? Yep. We are sorry, we don't have the remote control, so I will say next slide for the next slide. Okay, thank you. We prepare to not to have this kind of incident, but it happens. So next slide. Next slide, please. Yeah. Yes, this is Q&A. It's not a presentation there. Yeah. Yes, this is the outline of our presentation. So we are going to skip the background. The background is just one sentence. We are going to describe the epidemiology with the two sides that are the mortality and morbidity, and we are going to describe what are the challenges and the way forward. So the background is that we just come out from the UN high-level General Assembly that was devoted to the fight against tuberculosis, and they came out with a political declaration. So the head of state and government went to New York to have that commitment. And in our strategy plan, we need to translate the high-level commitment in our planning. Next slide, please. Yeah. So in Africa, all the state members of the WHO have convened to use the general TB commitment to fight against tuberculosis. In 1993, tuberculosis was declared a public health emergency, and now we are implementing the NTB strategy. So they are using this framework to align their TB response with the global commitment to implement strategy for detection, treatment, and prevention. Next slide, please. This is one commitment of the NTB strategy. We need to decrease the death. So we need to decrease the mortality. The next one is the decrease of the number of new cases, the incidence, and also the households that are affected by catastrophic cause because of tuberculosis. These are the milestones. We have the first milestone that were evaluated. The second is next to is 1 year, is 2025, and 2013 is not that far. So we are going to see where we are in regard of this high level commitment. They are very ambitious, but we think that we can make it. Next slide, please. These are the numbers that I need you to keep in mind. So you see, the global TB incident case is 10 million, and Africa has 25% of the burden. That is 2.4 million incident TB cases. But the good news this year with the TB report is that we have increased our notification by 18%. So we have notified 70% of incident cases. This is the good news of the TB report. So we are closing the gap, and please keep pushing. But unfortunately, we are bearing the death rate is very high in Africa, and we are having 30% of the global TB death worldwide. Next slide, please. Next. Okay, this is the age and sex distribution of the TB cases. So the missing cases occur in all the group, and we see that young adults are more affected, but the 30% incident cases that are not fine are taking us far from our high ambitious goal that we set for the NTB strategy. Next slide. Why do we fall ill with tuberculosis in Africa? We are in the HIV conference. All the progress in TB control in the region have been pushed by the tremendous result on HIV care. So this 1995, 95, 95 resulted in elevating the level of the immunity, putting people on IPT and decreasing the incidence. But this year, undernutrition becomes one of the most contributing factors that make people become ill in TB. And we don't know how to fight against undernutrition. So it's beyond the health sector. This is one big challenge. For HIV, we are pushing. Alcohol use disorder is also emerging, but it's also complex. Maybe let's fight against HIV is still the biggest one. And undernutrition, we are going to put on multisectoral strategy to tackle that determinant. Next slide. This is the incidence curve. So we are coming from far. 300 case per 100,000 inhabitants when we started fighting against tuberculosis with the Global Fund in the year 2000. And now we are our incidence now is 200 and 205, 207 per 100,000 inhabitants. This is the milestone that of 2020 when we met the incidence reduction. And this is the list of countries that reduce the incidence. You see South Africa in the list. They reduce the incidence, but the incidence is still high in that country. But the indicator was to reduce by 5% per year since the year 2015 till year 2015, your incidence. So we have achieved this for this country. Next slide, please. And for mortality, we have also made some progress. So this is the number of deaths that are related to TB in our region. We came from close to 900,000 deaths in the region to less than 500,000 deaths in the region. So this is where we are coming from. But the goal is really ambitious. Less than 70,000 deaths by the year 2013. We have to fight against this high mortality. And the mortality is very high among the people who are living with HIV. Maybe we need to put on the top of the agenda the directive of WHO on the care of advanced HIV disease. Next slide, please. This is the list of the high burden country, and there's a list that is renewed periodically, and more than half of this country that in the list are coming from our region. Nigeria, DRC, and South Africa, and Ethiopia, Kenya account for almost 80%, 70% of the TB incidents in Africa. If we use the Pareto method, what are the 20% country that account for 80% of TB cases? We find a priority, but we need really to eliminate TB in all the country. But these are priority country. In terms of elimination, those low burden countries deserve also attention because they will be the first to declare the elimination. So we need to make smart plan for those small island insular country so that they will become the first to declare the epidemic out under control, and then we declare some successes at the level of Afro. Next slide, please. So this is the milestone for incidence reduction. It was 20% reduction. Now we are in 23, but the milestone of 2025 seems very complicated. Maybe we are out of track for this indicator. So the question, with your idea, you are going to answer a QR code and submit your nice idea that are going to be taken into consideration, how to speed our response to reach that 2025 milestone in terms of incidence reduction. Next slide, please. For mortality reduction, is a 75% reduction by 2025 that we are aiming. So time is against us. So we are not on track. Next slide, please. For the catastrophic cause, this is also a more complex issue. 80%, 50% of our patients having TB, even more than 50% of patients with MDR-TB are facing catastrophic costs. So we need to think about catastrophic costs. And the beauty of the catastrophic costs is that we are making studies and we are not applying the result of those surveys. Why and where people are having catastrophic costs. Giving free medicine is not really the problem. Maybe they need food, they need transportation. There are many issues about that. So we really need to take into consideration the result of this catastrophic cost survey. They are not just there to report that the country has performed the survey. So it's a problem. And we are not going to meet because the target is zero family facing catastrophic costs. Next slide, please. This is in a nutshell our results. So increase on notification. We are using molecular diagnostics, but they are very expensive. Only for 50% coverage that is there. We have also increased the number of people who are diagnosed with MDR-TB, and the gap within the people who are starting the MDR-TB treatment and the people notified is really really narrow. This is a good result. So we are treating all the cases that are diagnosed, because in the past you diagnose someone and you make, let's say, 1 month in order to make all the clinical workout or even having the medicine to treat that MDR-TB patient. So the gap is closing, and we are using we have to scale up this new treatment regimen. So we are changing the regimen to improve the safety of the regimen, and also to take into consideration the patient well-being, because those older regimen were very toxic and have a lot of side effects. So this is the main message of our result in the response in the region. Next slide, please. And then prevention. If it's difficult to diagnose TB, maybe it's easier, and prevention is a low-hanging fruit that is not exploited in our region. So the main target of prevention in our region is people living with HIV. Yes, people living in HIV constitute the majority of TB cases, but they are covered. But the rest of the people are the ones that are undernourished, that contact people, and also the children less than 5 years deserve having this IPT. And we have developed new regimen that are even shorter and more comfortable and more user-friendly. And people They adapt it in their strategy, but they are not ordering in, and there's cohabitation with longer regimen that are not really comfortable. So last year there was even a decrease in the administration of TPT to people living with HIV, but an increase in the coverage of other categories. So this is the direction. So it's difficult to find someone with TB. TB is a big disease, but it's a rare condition. But once you have diagnosed your TB case, it's a TB case. And usually we send our community people to look around a rare condition. But we have the TB case in front of us. Let's do contact tracing, aggressive contact tracing, and give the TPT. Maybe it's one of the community-based intervention that can make the difference in a short time. So next slide. So the treatment success, we are really below the 95 success that we are need for the drug-sensitive TB. But for the drug-resistant TB, we are leading the race. So we have 71% success rate. But we can improve this by using this new formulation and having a more center-patient approach, because our fight in MDR TB treatment is that the center are very centralized. People want to make it hospital center, and we can do it in community. But in community, we also have the problem of infection control. That is also a big issue. So next slide. Okay, we are in the HIV conference. You know these figures. So we are bearing all the thing. Next slide. So the case finding among people living with HIV is not really successful. So we have 56% of our people living with HIV that are diagnosed with TB, but 91% of those who are diagnosed are put on ART. We can improve those. So we need to really see the guidelines and make sure that we put those people that are co-infected on treatment. Co-infection do not mean only TB, HIV, but it's TB, NCD, hepatitis, and it's patient center. Okay, I'm running out of time. Next slide, please. Next slide. Yes, this is the burden of the MDR TB cases, that the high burden country list. And next slide, please. Okay, for the budget, because to make all this, we need budget. So the commitment is we need 1 billion to fight against TB when we plan ideally, but we have only less than 1 billion that is available. So we are short of money. We have nice idea, but no money. So we have to optimize. So thank you. Next slide, maybe it is the end. These are the challenges. We are going to discuss about the challenges. Next slide. So missing cases, TB preventive therapy that you can also improve, and insufficient coordination among the actor. And next slide, please. Yeah. So the data source is coming from the new TB report. You can scan the code and have more complex statistics about TB. So thank you for your attention, and thank you, Madam Moderator, for your time.
Okay, thank you, Jean-Louis. And I think that it will help us to identify the best solution, because we need your help at the end of these presentations. The next presenter will share with us the Zimbabwe's journey towards the TB burden reduction and the classification as a high burden country, their achievements and best practices, and what are the remaining challenges and priority for Zimbabwe for this TB program. So the next speaker is Dr. Kube Manners. He's a TB HIV officer in the Ministry of Health, in the National TB and Leprosy Control. And he has been working for 3 years for now. And before this, he worked at Bulawayo Hospital for 10 years after completing his medical studies. And he's interested in the major public health challenges in Zimbabwe, including the management of TB, HIV, and the support on the end TB strategy. So over to you, Dr. Manners.
Thank you and good afternoon. Next slide, please. Okay, so as was mentioned, I'm going to give an overview of the national TB response in Zimbabwe and just highlight some challenges and achievements and some interventions that we think are innovative and can drive the program forward. So there you see our vision, a TB-free Zimbabwe, and then goals by 2026 to have reduced the incidence of all forms of TB by 80%, from 242 per 100,000 in 2015 to 48 per 100,000. That's in 2026. And then to also have reduced mortality by 2026 of all forms of TB by 80%, from 40 in 2015 to 8 in 2026. Next slide. So just to give a brief context in terms of where we are in terms of a TB in Zimbabwe. So Zimbabwe is in the top 30 list of high burden countries in terms of TB, HIV, and also MDR TB. So for 2022, the estimated incidence was 204 per 100,000. So it's in the context that in 2021, the estimated incidence was at 190. So we are seeing some reversal there in terms of the incidence. And then treatment coverage for 2022 was 56%, just a marginal increase from 54% in 2021. So in absolute numbers, we saw some increase of close to 2,000. But then looking at the new estimated incidence, we realized that the increase is pretty much minimal, really. So missing cases of more than 14,000 with reference to the estimate. Then TB HIV co-infection rate standing at 51% in 2022. So we are seeing a decline in the trend of TB HIV co-infection, but amongst those who are notified. Next slide. And then in terms of access to diagnostic services, we have a total of 155 the expert machines, basically for detection of TB and also characterizing rifampicin resistance. And a recent development that is that we now have 1610 color expert machines. These are machines that are able to further characterize the resistance pattern of TB. We previously had 5, and I think a week or 2 back, we were able to deploy more of these in the various sites. Then access to digital X-ray machines, we have 50 as a country, but the computer-aided detection component is not part of these X-rays at the moment. Next slide. And then this sort of shows the incidence notification gap over 10 plus years. And you'll see that from about 2019, the gap sort of widened. This happened before COVID-19. So we know that we might give some blame sort of to COVID-19, but we know it goes beyond COVID-19. The missed cases are basically increased over time, even a year before COVID-19 really took effect in terms of disrupting implementation. So we try and have interventions now to close that gap in terms of our coverage. Next slide. And then TB HIV collaboration. I think this is a conference mainly in the name of HIV. So we can safely say that in terms of screening people for HIV, at least among the notified, we are doing very well. Look at the blue line at the top. That's documented HIV status amongst notified TB cases, and we have been inching and have reached 100% for 2022. And then in terms of enrollment into ART, for those who are co-infected, that's the green line just below, and we're standing at 95% for 2022. I saw that for Africa, we're at 91, as you did mention. So I think we're doing quite well as a country on that indicator. Next slide. And then with reference now to the UNHLM targets for the period 2018 to 2022. So in brief, if you look at the last column there, that's where we have performance, if an achievement against target. And the red shows where we didn't reach the target. and then the green is where target was reached. So TPT for PLHIV, I think for those who attended the session on Monday, it was highlighted that Zimbabwe performed very well on this indicator. But for the rest of the indicators, not as good. We didn't reach the target. For TB case detection, we had 81%, childhood TB 67%. And for childhood TB, really, we expect to get some cases, at least from the index cases that we have identified during contact investigation. So because of leakages and some other challenges around contact investigation, we're missing these children. Even in terms of specimen for testing for TB in children, we had issues. So recently we adopted the use of stool and did the necessary capacity building. And this is something that is still new relatively. So I had to see the impact of this building of capacity, both with healthcare workers and the labs in that regard. And then MDR TB case detections, 35%. But when you reference now to the TB in general of 81%, we see sort of there's some discrepancy there, because we know that case finding for DRTB is nested within the conventional TB case finding. So that is why currently we're in the process. We have just started the process of a DRA survey to just appreciate better the burden of MDR-TB, of DRTB in the population, to better align our targets to the real burden that is there. And then under 5 contacts TPT, we managed to achieve 41%. So as I said, there is some leakage around contact tracing, and also sometimes confidence amongst healthcare workers in terms of enrolling these children into TPT. And then TPT for those 5 years and above, the performance was even lower at 33%. But some factors have to do with that. We risk groups and providing TB prevention interventions, as we mentioned earlier. So we think pulling together through joint multi-sectoral accountability will leave no one behind and will be able to end TB in Zimbabwe. Thank you very much.
Thank you so much, Dr. Kube. So we have heard from WHO, from Ministry of Health. Now we need to hear from the civil society perspectives. So our next speaker will be Senator Pierre Flambeau Gayap. He will participate remotely, but let me introduce you, the Senator Pierre Flambeau. Was the director of L'Oréal France and then managing director of Ron Poulenc in Cameroon. And he is currently an entrepreneur and law teacher. In politics, Pierre Flambeau Gayap is a senator and a member of the Senate Bureau of Cameroon for 11 years for now. He leads many parliamentary caucuses, such as the Parliamentary Caucus on TB. And as well, he's the president of the French-speaking region of Africa and Europe. He has a doctorate of pharmacy and as well master degree in public health. So this is our pleasure to call Senator Pierre Flambeau. We cannot hear your voice.
Okay. So I'm not the senator, I'm just a translator. And the translator is sometimes a traitor, but I won't be that. So I will translate. So the senator went and looked for data on TB budgeting in his own country, and he has shared some data. He has also dig some data that are available in the public, available publicly to analyze the trends of financing TB in Cameroon and in the region. So I'm going to make it short. Next slide. Next slide. Next slide. Next slide. Yeah, so it's going to describe the context. You are going to skip the epidemiology. It's not me. Next slide. Yeah. This is the landscape of TB in Cameroon. This is the burden. Just having an incidence of 44,000 TB cases that are incident. And there's 10,000 people that are dying for TB in Cameroon. So you can compare it to Nigeria and to the rest of Africa. It's not a big high burden country, but it's a TB, HIV high burden country. Next slide. So this is the table that shows the TB financing in Cameroon. So we go to the UNHLM and we commit that you are going to fund TB. So there's domestic funding and there's a global funding and also the commitment at the UNHLM, and there's the gap at the end. So we have the ambition, we commit. Sometimes the country leverage some internal resources, but the economic constraint is also a barrier to TB and health financing as a whole. Next slide. And this is the pattern for Africa. So we have a decrease in domestic funding and also a stagnation in international funding. So we are really short of money. In my first presentation, we need 1 billion and we need 4 billion and we only have close to 1 billion. So the gap is very large. So we have idea, but we don't have money. Next slide. So the previous slide, please come back. Yeah, so he is advocating the crucial role of the US government, that is the first founder of the Global Fund and also the first bilateral partner that is financing fight against TB and HIV. But he said that we need to innovate in order to fund the TB HIV response. Next slide. So this is what I described earlier. So there is a stagnation in the level of internal domestic financing, and even at the level of Africa, there's a decrease in domestic funding, and there's also a stagnation of international funding. So the country commit but they don't fulfill their commitment because of many reasons. Next slide. So this is a repetition. Next slide, please. The opportunities. So we can innovate in order to increase the health financing. We have the Abuja Declaration that is not even reached, so it's an eternal debate. We won't finish it today. So we can also have new taxes on tobacco and other things like sweets and salt, and so we have pouch of where we can puncture the money. And we have also to the coordination, better coordination of the actor. So the coordination of the actor might decrease the level of duplication and increase the efficiency of the financing that is already available. That are the opportunity that we can explore. Next slide. Maybe it's a call of action that the senator made. So he's calling the government and the partner to increase funding against the disease, especially TB and HIV. Thank you for your attention.
Thank you so much for this call as well. And our next speaker will be Miss Makaita Gombe. And she will share with us the high-yield intervention for TB prevention and control in specific contexts, the lessons learned from TB HIV project implementations and other successful initiatives, and how to adapt and scaling up the effective intervention for broader impact. Let me introduce for you Ms. Makaita Maka Kombe, and she is the technical director of the Oram Institute in South Africa and the program lead for Impact for TB, a short course TB prevention market access project that has catalyzed the uptake of more than 4 million patient courses of 3HP across 78 countries globally. She is an health economics and finance professional with 15 years of strategy. So a background experience on analytical and program strategy spans across the public, private, and NGO sector. So we need to hear from her. So over to you, Maka.
Thank you. We could have cut short the introduction to save time. Next slide, please. So I'm going to tell the story of the Impact for TB project as we move to the next slide. It really came at a time when we had longer TPT regimens and we needed something shorter. There was a regimen that was available that had previously been used in the US, but it was at a price that was not accessible to low and middle income countries. So what this project did really was generate evidence for how this could actually be used within the low and middle income country setting. It is 3HP, and at the time the formulation was 9 pills per patient. And then if you take the vitamin B6, that would be 10 pills per patient. So we know that from a formulation perspective, that wasn't going to be easy to scale up. And then we also worked to increase the supply. At the time, there were only about 180,000 patient courses globally. That was not going to be enough. So we also worked with manufacturers to incentivize for the production of more volumes. And then we also had a large evidence generation portfolio for the different groups. We know there are children as well, there are pregnant women living with HIV, and just really what service delivery models could be used. Next slide, please. So what we actually found was there were a myriad of issues at the time, and because this started during COVID, a community intervention automatically had to be put into place because people couldn't travel to health facilities. And then in terms of clinician training, I think previously there had been a lot of memos that were sent out. Healthcare workers, this is what we're doing. You need to prescribe TPT. But one of the strategies that was taken on was to actually really explain to healthcare workers what it is that they were prescribing, how does it work, how does it cut transmission from infection to disease. And we found that was really helpful because even the nurses said, yes, now we know what we're doing. And that helped. And then even so the community work that I mentioned, and it was really prescription could be done within the community and people could take their treatment on their own, even though it was once weekly. And then for people living with HIV, really the use of the DSD models that had already been established within HIV programs were just leveraged for this work. People could get the full 3-month supply, and then then they could, there were a few telehealth innovations that were employed in order to check on people. Have you had any adverse events? How is it going? Have you vomited? No, you can continue taking. And usually after the third dose, any adverse events would self-limit and people actually managed to complete TPT. And then M&E, as was anything new, it wasn't already in the books. So it needed to be put in the books so people could actually see if people have taken it up and if they've completed. And then the last bit that was really critical that we've been talking about is this multi-department collaboration. So what also happened within this project was we know that TPT is part of a few different programs. It's within the TB program for household contacts, within the HIV program for people living with HIV, within family or maternal and child health for children, the contacts as well. So it really was coming together of everybody, quantifying how much we need, what it is that we, how is it exactly that we can actually do this. And then once that was done, we found that even the funding partners also came to the table. So how much is it that you need? How much can we fund? But the second one, funding partners can't come to the table if you don't have that initial collaboration. We also had a huge community component across the 12 countries that we're working with and beyond that really helped with the demand generation within the community, but also advocacy for changing the guidelines, making sure that some of these short course TPT regimens were actually available in country. So the communities did also lead within this project. And then finally, also the private sector. We do know that there's some people living with HIV that seek care within the private sector. Then what happens to them? They also need to have access. And we know a few countries also did pilot having this within their fast track programs out of a pharmacy in order to ensure that everybody is reached. Next slide, please. So this is the initial data that we saw. This is data from 9 countries. These are 9 countries, mostly in Africa, Cambodia, Indonesia, South Africa, Zimbabwe, Tanzania, Malawi, Ghana, Ethiopia. Have their data in here. And what we saw is for people living with HIV that newly initiated an ART, we did have a high completion rate if you compared to previous treatment completion rates that we had with 6 months of INH or 9 months of INH that ranged between 30 and 55%. But we saw it climb to about 77%. And then for the people who were stable on ART, it was as high as about 97% treatment completion, which I think is a far cry from, you know, a lot of what the programs could accomplish on their own. And what we suspect is the reason for the lower rate among newly initiating PL-HIV is because they're starting ART, they counseled on their daily regimens, and then they get another regimen that's once weekly. So that might have affected their adherence as well. Next slide, please. So this is the profile of what 3HP looks like currently. So what I mentioned, the 10 pills, is that first slide there where you use 150 milligram formulation, which is what we had at the beginning of the project. But through interventions, we actually managed to reduce the pill burden to 3 pills of 3HP plus the vitamin. And then we also now have a 300 milligram single that can be used for 1 HP. So 1 HP is daily isoniazid and rifapentine at a different dosage to 3 HP, and it can be taken for 28 days. So I've included there the price of 1 HP. Depending on which pills you use, the price will differ slightly, but for 3 HP, the price currently is $10 per patient course. It's $9.99. And this has been through a lot of efforts through starting within this project, but also other funding partners have taken it on, and the price continues to come down. Next slide, please. And this is a summary of what I just talked about. So the price right at the beginning of the project was at $72. It came down to $9.99. The production capacity went from 180,000. Now we have over 4.2 million patient courses in production. So countries can continue to scale up. We have over 78 countries that have already procured this. And then in terms of what's actually available, we still have the 150 milligram single that's currently used for children or some countries who can't access the generics. And then we have McCall's and Lupin manufacture the generics. And then we have a pediatric formulation that's also coming soon. So it should make it easier for children to also take short course TPT. Next slide, please. And then, so this is just a slide that highlights where, the complexities within children. Currently, we don't have evidence for 3 HP or 1 HP in children. It is being generated within the project. It's a project called Dolphin Kids, where we're trying to measure how safe it is to administer with DTG, but children on efavirenz can use 3HP, but those on PIs cannot use 3HP. So we found that within the project, a lot of children were still using 6 months of INH, and even with the pediatric formulation, it will largely help those children who are not living with HIV, who don't have any drug-drug interactions, and then we hope to get evidence in 2025 for children living with HIV on DTG. Next slide, please. So these are just reflections that we got from the program, right? 3HP was a game changer for most people living with HIV because it went from 6 months daily to 3 months once weekly, 12 doses. And then we do have the child-friendly formulation that's coming. So within a year or two, children should also be able to come down from 6 months to 3 months once weekly. But having said this, we also did see that there are some people for whom the intermittent dosing doesn't work. So there's some governments that blatantly said, no, we're not taking this up because these are people who are used to taking medicines every day, and then you want to give them once a week. You know, how would that work? 1HP could be an option for that. It's daily for 28 days. If I'm to share a story from the initial Impact for TB implementation, there was a particular person whose lifestyle is very migratory, and they suffered adverse events. When they went back to the clinic and the nurse probed what exactly happened, they said, you know, I really want to take TPT, but once a week doesn't work for my lifestyle. So they took the 12 doses daily. So they finished it in 12 days versus in 12 weeks. So perhaps that person, 1HP could be better. I think we talk about HIV prevention and all the different options and how it needs to suit the user. This is one of those things where countries can start to differentiate their programs based on the profiles of people. And then policies. Policies are very, very important because, as I mentioned earlier, there's some countries whose patients are still taking 10 pills because their regulation doesn't allow them to access the generics, and the generics will have the better formulation. So if countries can change their regulations in order to be able to adopt other regimens, then it can also work for the people they're serving. Again, stakeholder collaboration, as I mentioned, the communities need to be involved, demand generation, all of the work, and to make sure that a product is actually fit for purpose. Sometimes it comes and it doesn't look like it works, but if we look at our system and we tailor it to our system, then we know exactly what works. And then, so the expanded 1HP really could work for possibly ART naive, as I mentioned from the data earlier, displaced people, people in conflict areas, adolescents or minors or migrant groups. And we know, like for prisoners as well, we have one country that's actually accessed this to use for prison populations, because as we know, sometimes it's very transitory. You're in for 30 days in remand and then you leave. So do you give them the rest of their meds? Do you bring them back? How does that work? And then both have been modeled to be cost effective. And I just want to end with all the challenges that we just spoke about TB treatment, that we're not doing well at finding people. And because we're not doing well at finding people, it's better to actually just prevent than to wait to not find those people and we have other statistics. So when you think about it, when we modeled it, we found that both 1HP and 3HP are cost effective despite the price difference. If no TPT is provided, we expect 4 out of every 100 people living with HIV to be treated for TB. And this estimate is actually higher for children living with HIV, because for children, we actually have a lower case finding rate. And then the last estimate is by 2030, if we provide TPT, we can save about 700,000 children's lives and about 150,000 people living with HIV's lives. Thank you.
Thank you so much, Maka. So now we need to have your collaboration, participation.